Good afternoon. This is Matthew Mary, Director of Emergency Preparedness with the Virginia Hospital and Healthcare Association. Thank you for joining us for the Virginia Healthcare Emergency Management Program quarterly webinar series, the Virginia Healthcare Hurricane Season Preparedness and Response webinar on May 18th, 2022. And this webinar officially kicks off our initiatives for the Virginia preparedness efforts for the 2022 hurricane season. A few housekeeping items. All lines will remain muted throughout the duration of today's webinar. If you have any questions for the panelists, please type them in the chat box. We'll host a brief Q&A session following the presentations. Slides and additional resources are in the handout section for your reference. The slides and recording of today's webinar will be emailed out to all registrants this afternoon. On behalf of the Virginia Hospital and Healthcare Association, I'd like to introduce our speakers today. Patty Montez, Director of Systems Emergency Management, Environmental Health and Safety, Centera Healthcare, and our federal partner, Leanne Erdman, Emergency Management Specialist, Veterans Affairs Medical Center, Hampton. Without further ado, I want to introduce our first speaker, Patty Montez. Patty, I'll turn the call over to you.
Thank you very much, Matt. As many of you will remember, back in 2019, we had, or 2018, I can't remember which. Anyway, it was Hurricane Florence was threatening the eastern region of Virginia, and it prompted the evacuation order from Governor Northam, and Centera had to evacuate part of a hospital and then had to also evacuate a long-term care center. So Centera Albemarle Medical Center was the hospital we had to partially evacuate. It is in North Carolina, but those patients came to Virginia. It's located in Elizabeth City. It's the only hospital in the northeastern section of North Carolina for about a 50 to 75 mile radius. Typically has an average census of 65, sits on a river, and unfortunately the emergency generators, which were constructed prior to Centera purchasing the property, also sit on that river. Next slide. Centera Life Care Currituck sat directly on the Currituck Sound in North Carolina. It was the only long-term care for the entire county of Currituck, which is a large county, and we had to evacuate the entirety of this location before any of the access roads would be flooded. So it was a huge priority for us. Next slide. Centera Life Care Norfolk is located on the Elizabeth River, has 131 beds, including 26 respiratory care or trach patients on ventilators. It had never been evacuated, but sits in Zone A, and was going to be quite a lift for us, particularly around the 26 trach patients for evacuation. Next slide.
Hi, my name's Leanne Erdman. I'm from the Hampton VA Medical Center. Hampton VA Medical Center is a healthcare system that consists of our main facility and 4 community-based outpatient clinics, plus the Peninsula Town Center. The Peninsula Town Center is where our Office of Community Care, which does the off-campus resources, provides resources for veterans to use off-campus healthcare, maintains a large presence at Peninsula Town Center. We have more than 2,000 full-time employees, and we serve 62,000 veterans from 6 counties in Eastern Virginia and 9 counties in northeastern North Carolina. We are the largest and fastest growing VA on the East Coast, and we are the fastest growing VA in the country. We're a teaching facility, and we maintain a 169 bed domiciliary where addiction patients stay. We have a 112 patient bed long-term care community living center, which is essentially our nursing home. And we have a 10 bed freestanding hospice facility, and we have a spinal cord injury unit. We're located on 78 acres, and as I mentioned, we are, one of the largest facilities in the nation. Next slide, please. We're unique because we're uniquely veterans. We don't see any other patients except for veterans. We're a federal facility, so we are bounded by federal law and policy. We're surrounded by water. We're in Zone A. As you can see in the picture, we have a 6-foot seawall that surrounds our facility. We flood frequently. Our vulnerable patients include our spinal cord injury, our high-risk flag mental health. Those are the patients who are at risk of harming themselves, our community living center, and our domiciliary, which is where our addicted patients stay. Next slide, please.
Okay, Centera Albemarle had not been evacuated while it was a part of Centera. And this was going to be a first for us. We do annually exercise our evacuation plans, and we do a lot of incident command training for the leadership at the facilities and at the system level. It is a difficult decision to evacuate any patient, long-term care or hospitals, but it is particularly difficult to do the risk analysis. Is what is the greatest risk to the patient, the evacuation or the staying in place? Next slide. Now, the Currituck Life Care had been evacuated 3 times prior to Florence. 2012, 2011 was Irene, and 2003 was Isabel. And again, there's always training going on around evacuation with long-term care, because it's as history has shown us, it's a very real possibility, and particularly for this facility, because it's so easily cut off, is something that's happened frequently. Next slide. Now, the Norfolk long-term care had never actually been evacuated, but we learned with Irene that it very easily could get flooded, and then all the access roads with Hurricane Matthew, which happened previously, could get cut off. So we really placed some emphasis on evacuating that facility, but we had, prior to the occurrence of Florence, we had not clearly identified where the trach ventilator patients would go, and that was something we had to work out rather quickly. With the new Know Your Zone maps that were launched in 2017, it actually firmly placed the Norfolk long-term care in Zone A, and we had to continue to work on that. Next slide.
For the Hampton VA Medical Center, we do have annual hurricane evacuation drills and tabletop exercises. We also, I did not put on this slide, we also have dual use vehicles that we have a requirement to set up, configure, and load patients in once a year to practice for our evacuation. Hurricane Florence was the first time that we completely evacuated and locked the doors. We always do a partial evacuation of our most vulnerable patients, but Hurricane Florence was the first time that it was a full evacuation. There was no full-time emergency manager until 2019, and that is me. Our evacuation decisions have to be coordinated through our headquarters, which is located in Durham. We are considered what they call VISN 6, and VISN is our network. We have a Virginia emergency manager who is assigned to our office. She is assigned to the Office of Emergency Management for the VA in Washington, D.C., but she lives and works out of Virginia. She is tasked to travel to Hampton to assist in any way possible during an evacuation. And our plans include the Richmond VA for our spinal cord injury patients, and Martinsburg, West Virginia for our mental health patients. And that plan's called the Hampton Inn Plan. Incident command is training is required by federal policy and by VA policy for our leadership. Next slide, please.
Okay, so ready, set, go, and then hold. When it came to Sentara Albemarle, it's really an older building, and we made the decision early on to evacuate the 5 critical care patients that were there to Virginia Beach General, and that's Beach General you see there on the slide. And we did that on Tuesday, and that's when we were clearly in the bullseye for Florence to hit the eastern region of Virginia as a category 3, 4, or 5 storm. We had plans in place to do a total evacuation of the rest of the building to occur on Wednesday once we evacuated the Norfolk long-term care. So we kind of phased this. We were getting the critical care patients out first, then we were going to get out the long-term care in Currituck, then we were going to evacuate the long-term care in Norfolk, and then we were going to come back to SAMC to evacuate the rest of the patients. We figured we'd have about 30 patients to be evacuated at that time, and I don't want to use the term forced, but we had to entertain the idea, if we close this facility, and it's the only facility for a 50-mile radius, do we need to leave a stay team in place for anyone who might show up on the doorstep despite the hospital being closed? Because no matter what communication we put out to the public, and it would have been extensive to let the public know we were stopping services, you're going to miss somebody. And the last thing you want is somebody in need of medical care to show up on your doorstep and the doors be locked. So we struggled and came to the decision that we would leave a stay team in place for such, if that eventuality happened and somebody showed up requiring medical care. And what we learned is this is not a matter of leaving a doctor, a nurse, a security officer. This team actually ended up being about 15 to 20 people, because you need a leadership presence, you need a facility presence, you need the clinical care presence. Yeah, you can leave, the emergency room team, but you've got to have a shift on and a shift off. When you struggle with this decision, and I know many of us have not been faced with evacuating a hospital, you have to make that decision about closing those doors, and is there somebody going to be there and somebody not going to be there? Fortunately, we evacuated the critical care patients, and then that was on Tuesday, and then on Wednesday, Florence changed her track. So we did not have to do the total evacuation of that hospital, which was good. Next slide. We did completely evacuate the Currituck long-term care. And that was the second phase after we moved the critical care patients. We had arranged transport. At that time, we had a medical evacuation bus that was grant supported, and we used that to help us evacuate the bedridden patients. We also have Sentara Pace, which has 27 handicap capable buses that we use to help us evacuate the remaining patients, and we very sparingly used the Pasquotank Currituck County EMS to move patients, because they still had to remain operational during that time. And we evacuated the patients and the staff to care for them, and then had to do some arrangement of sheltering of that staff and their families, because they did bring their families. Once we distributed these people between our long-term cares in Chesapeake and Virginia Beach. And that there took a lot of coordination, because we also brought up, the pharmacy supplies, any medical supplies they had. And, everything that was needed to take care of that patient in the facilities that we were transferring them to. Next slide. And, in moving all those patients, that's a big coordination. So the long-term care in Norfolk was not going to be evacuated until Wednesday. And fortunately, that's when Florence changed her track. So we were again on hold. Governor Northam issued that mandatory evacuation order for Zone A. The Norfolk long-term care was in Zone A. We determined where we were going to send those patients, and it was going to be divided up between our other long-term care facilities at that time. We eventually landed on the ventilator residents of that facility would actually end up going to Sentara Norfolk General Hospital, into the hospital for extended recovery, which was within Norfolk General, to take care of those ventilator patients, because there were no other options in the long-term care community to house those patients. And again, fortunately, Florence changed her track. We didn't have to make that move. But this is one of the things we learned, is when you have that vulnerable population and then you have a specific cadre within that vulnerable population, you truly need to identify where you're going to send those specialty patients prior to the evacuation. Because if we had to do this in a more rapid manner, we would have been very challenged as to what to do with those folks. And we did not want them to end up in emergency rooms. So a lot of planning, had to happen on the fly, and we were ready. But even though the governor put in the mandatory evacuation order for Zone A, where Norfolk long-term care sat, this was one of those decisions that had to be made. What was the risk of evacuation versus the risk of staying in place? When the storm turned, the risk of staying in place decreased dramatically, and we elected not to evacuate that facility unless the storm changed track again. So we had everything in place should we need to pull the trigger, but we actually made the decision not to move. Next slide. All right. So as we all know, Florence was the first of its kind and turned south, and actually hit in the Wilmington area of North Carolina. So that happened Thursday into Friday of that week. And then Saturday morning, Sentara received a call from the state of North Carolina requesting assistance with helping the healthcare system in the state of North Carolina. And they were setting up a Ford, essentially a Ford emergency department in Kinston, North Carolina, and requested our assistance. And since our response had terminated, we were able to deploy 2 teams who spent 4 days each down there in Kinston, North Carolina. They treated 296 patients in 8 days. 10% of the patients had to be transferred to a higher level of care. And they treated everything from minor injuries to chronic illnesses where people lost their medications because of the flooding, to trauma for patients who were injured, and then a number of OB patients who decided they were going to deliver. It also became the county debriefing center where everybody came to talk about what was going on. It kind of became a hub for residents. So in addition to providing medical care to the residents in need, it also became a dispensing center. So people were able to come there to get water, to get foodstuffs, and things of that nature. Next slide. So this is what Kinston looked like. These were the teams. So if we were actually on a high point, and if you left the high point during high tide, this is what you saw. So if the team left during high tide to go do a rescue, and they did participate in some rescues, they were going by boat. Next slide. This was the first team that went down. And we had day and night coverage. It was operational 24 hours a day. Next slide. This is the second team that went down and provided service for their 4 days. They had to go in and evacuate part of a nursing home because the sort of levee structure around it failed and it started to flood. So in the middle of the night, in the dark, they were doing helicopter rescues from the nursing home, flying them to a landing field where this team was. This team would do a medical evaluation and decide if they needed medical treatment or if they could go to the shelter, which was not what we expected to be doing, but it was part of the response that we helped supply to our partners down in North Carolina during their time of need. Next slide.
Okay, the Hampton VA's response to Florence. We convened incident command, and for us at Hampton, that means all hands on deck. As you can see in that picture, the lady in the yellow hat, who is our powerhouse, Dr. Simmons, she was the acting executive director at that time. All our activities and all our planning here at the facility were based on shelter in place because as a federal facility, we are not normally moved by the directive of the governor. We are, as a federal facility, we do not have to abide by those same guidelines. Our routine procedure is a partial evacuation of our facility, and that's routine for any storm because we coordinate with Richmond for our spinal cord injury patients and Martinsburg for our inpatient mental health patients. They are some of our most vulnerable patients, and they are equipment extensive, and it is too risky to move them in a more acute situation. So we just we move them proactively. And our initial plans always include pre-positioning our geriatric and hospice unit, which I mentioned is a separate building on our campus. And we pre-position them into a wing in the facility in case we have to evacuate them. Next slide, please. Our high-risk veterans in spinal cord and mental health, we prepare them for transport. That includes getting them transferred to another facility in our bed management solution system, which is a federal system that we use to move our patients. We do a lot of coordination with families. That includes families that want to take their loved one home with them, that the patient will be released to their care. We activate our ground ambulance contract, and we bring in our dialysis patients early. When we activate our ground ambulance contract, they are used to assist us in moving some of our spinal cord injury patients because they can all be moved in our dual use vehicles. And we begin a vulnerable patient accountability. What that includes is notifying anybody that we have labeled as vulnerable and contacting every single one of those patients to ensure that they do not need any assistance. And that includes our homeless populations. We actually send teams out to the homeless shelters to ensure that any veterans in the homeless shelter, if they have any needs or they want to be evacuated, that they're taken care of. Our home health team goes out and makes sure that any of the home health veterans that we have all the health care, health equipment, their oxygen, or their medications. And if they have any needs, they'll take care of that. We will transfer any of our patients who families do not want them transferred to Martinsburg or to West Virginia. We will do our best to transfer those patients to local facilities. So some of our mental health patients will go to mental health facilities in Virginia Beach if it's indicated, or to other facilities if we're able to make that contact. And we even have one individual that lives in North Carolina that every time there's a storm, that there's an evacuation, we send a vehicle to pick up that one individual, because our core patients, the 62,000 patients that are registered with us, we have a responsibility to the veterans in our community to make sure that they're taken care of during a storm. Next slide, please. Our dual use vehicles, there's a picture of them there. It looks like a giant bus. They're very heavy. They have wheelchair lifts on them. They were prepared, and we also request that Richmond sends down many they have available, and they often send teams down with that to assist with loading. Our ambulance arrived for the transport of our high-risk veterans. Our surgeries were rescheduled, and we coordinated transfer to the local mental health facilities or long-term care facilities. And as I mentioned, our home care team coordinated with pharmacy, oxygen, and dialysis to ensure continuity of care. And there's where we sent transportation to pick up our one vulnerable patient, because we will pick up the one vulnerable patient. A lot of our veterans do not have family or any support system, and we are their support system. Our homeless population tracked every single homeless patient, and that's a major kudos to them and their hard work. Next slide, please. We came to the point where we had to make a decision to evacuate or stay. As I mentioned, we're a federal facility. Much like the Department of Defense, we are not bound by what the governor says. But on November 10th, Governor Northam announced a mandatory evacuation for low-lying coastal areas, Zone A. And as you saw from the initial picture, we have a 6-foot flood wall, and even during the storms last week, the water came up on campus. Our initial plans were to remain here until a coordination call with our network director in Durham, and they discussed the liability of sheltering in place. And at that point, a determination was made to fully evacuate the medical center based on a mandatory evacuation. Never been done, never abided by the governor's directives in the past. At that point, all appointments were rescheduled. Our community-based outpatient clinics brought all patients in early, and they rescheduled them, or they rescheduled them. Next slide, please. And then we began our evacuation. As you can see, the spinal cord injury patients have very heavy equipment, and most of them reside permanently on our campus. Many refused to leave their possessions at the facility, so that became a logistical complication for us, because they don't have suitcases. Most of them that live here, we had to throw whatever we could into garbage bags for them to take their possessions with them. Next slide, please. As I stated earlier, many of our veterans have no support system, and they depend on the support of our medical center and the VA to take care of all their needs. Next slide, please. In less than 24 hours, this facility was completely evacuated, and every patient was either transferred, and we continued contacting registered vulnerable veterans until 100% accountability was made. Dr. Simmons ordered everybody to leave, lock the doors, and lock the gates. This is our SCI dining facility. As you can see, the tables, a lot of the tables have no legs so that the wheelchairs can go under it. They have electric, or not electric, they have motorized wheelchairs. And you're looking out the window right onto the Chesapeake Bay. To the left of that picture is the bridge. Next slide, please. And what we learned.
Yep. So lessons learned from Centera, particularly around the hospital. We had never evacuated it. We had a brand new hospital president. She'd only been there about 6 weeks when this happened. So we were helping her with all the decisions that had to be made. In Pasquotank County, at that point, Sentara Medical Transport had a no competition MOU with Pasquotank, meaning if there was a transport from the hospital, Pasquotank would handle it. And if they couldn't handle it, then we could bring in medical transport. And we had to work through that with Pasquotank. They transported 2 of the 5 patients, we transported the other 3. But it's a give and take, and that is not a normal agreement that's in place with most EMS agencies, but was here in North Carolina. We had some initial challenges with the intensivist out at Beach General, but we worked through that with leadership. They were a little hesitant, but after some conversation, we were able to get them to accept. And then again, it was that decision, do we fully evacuate? Do we partially evacuate? Do we evacuate in phases? We did evacuate in phases, and fortunately had a change in the track of the storm where we didn't have to complete the full evacuation. And then the concept of who is the stay team and who is that comprised of? And, there's also, they needed to agree and volunteer to stay. We really couldn't mandate that person stay. Included on that slide is just our flow chart for deciding whether or not we would evacuate a facility. We did have this in place prior to this event, and it was utilized for doing the decision making, and it's since been updated. Next slide. Now with the long-term care, we had the same evacuator shelter in place decisions, but it was while we were moving more patients, it was a little easier decision because the Currituck long-term care had flooded so many times. Moving the supplies and the equipment with the patients was a challenge. We did have to bring in a box truck to help us move all of that because we didn't have space in all of the resident transportation vehicles. Notifications of all the family and responsible parties. We had to put a team on that to make sure everybody got notified about where their family member was going. The sheltering of staff, because the minute the evacuation order came out up here in Eastern Virginia, every hotel room booked. So we had some challenges finding space for the families and the staff because the families came, the staff families came with the staff, which is understandable. And we had to make some accommodations for that. Storm tracking, the track change was good and bad. And because of not just Sentara's long-term care evacuation, but because many long-term cares evacuated in the Eastern region, moving discharges out of the acute care facilities, not just for Sentara, but for everybody in the Eastern region became a challenge because if you were evacuating, you certainly weren't taking a new patient. And if you were receiving evacuated patients, you weren't taking new patients. So we did have some delay and some patients who were delayed several days because of the long-term care evacuation that occurred within the Eastern region. We also had some challenges between the North Carolina CMS requirements versus the Virginia CMS requirements. And fortunately, North Carolina CMS issued 1135 waivers that helped us with that. But the issuance of those 1135 waivers in response to a storm was kind of a new concept for North Carolina as well as Virginia. So that took a little bit. We evacuated that long-term care on Tuesday. We did not return to that facility until the following Monday, which means there was a fair amount of fatigue for the evacuated staff and the incident command team, as well as the family members of the staff who also evacuated and were being sheltered. Next slide. This slide is referring to the work we did in Kinston. Transportation was a constant issue every time the tide came in. Food and water. While North Carolina was providing water and providing food, with any response such as that, the community really wants to outreach and help supply the first responders with things. So there were church groups showing up with food for the team. There were these food trucks showing up with food for the team down there. And we had to be really, really careful about what they accepted and what they didn't accept, because that entire region was under a boil water order. So you didn't know how they prepared the food, and the last thing you wanted was to give your staff that food and then have them get sick with a waterborne illness. That kind of happened in one of the shelters where a church group showed up and provided food to the shelter. Nobody thought to ask about how it was prepared, and the next thing you know, there was an outbreak of a diarrheal illness in that shelter. So that's an issue. Charting, we had to become familiar with their paper charting form. We taught them about how to utilize vertical care, which is a concept used up here in the Eastern Region hospitals. You know, if somebody's vertical, they can sit in a chair. Not everybody needs to have a stretcher. We helped them develop an armband protocol because they had no patient identification procedures in place. Getting prescription filled was a huge challenge down there because everything was closed because of flooding. There was one pharmacist, and it wasn't advertised, but this one pharmacist, the team was able to call her, and she would meet the patient at the back door of her pharmacy and hand them their prescriptions free of charge. It was kind of kept really secret because we didn't want people to just start banging on her back door and expecting to get medications. So it was a one-to-one handoff, and we would send the patients if it was medications we didn't have, and there weren't a lot of medications in this cache that North Carolina had, but we took care of that. And then reimbursement. These residents and patients and all were not charged, and what we did learn, and it was fine from Centerra's perspective, there was no reimbursement for the services that from North Carolina to Centerra for providing the staff. That was fine. You know, to us, it was being good community partners. We weren't looking to be reimbursed for the man hours, but we discovered there's no mechanism for private healthcare to be reimbursed at that time by the state for services being rendered in an emergency response, such as a freestanding ED in the middle of a flood zone. So that was a little, everybody kind of put threw their hands up in the air and go, what? And I don't know that that's been addressed, you know, because it wasn't long after that we were dealing with COVID. But that was one of, I wouldn't consider it a challenge. But we did have some, next slide, some issues around credentialing, where the nursing staff and the respiratory therapist and the radiology people down there very easily could be credentialed in the state of North Carolina. We had to take a couple extra steps to credential our providers who went down, but we were able to do it. So the things that went well, let me tell you, System Incident Command and the business unit commands worked. Using the HICS and the NICS 255 and 260 work. All the patients and residents were evacuated and returned without any incident. We didn't lose anybody's equipment or belongings. I mean, that was great. We didn't lose anything. Having system coordination of the multiple sites really made things a lot easier. We didn't have people battling for resources. We kept the long-term care residents and ICU patients in blocks. So whatever roommate you had at Currituck, you had wherever you were evacuated to. So we weren't having people, because they get very used to each other and they really don't like change. So it was upsetting enough. So keeping roommates together really worked. All the facilities evacuated used the same EMRs within Centerra. We did daily phone calls to families and responsible parties, and leadership was there rounding on everybody. Lessons learned, sheltering of staff. We were challenged with that. Reoccupying the facilities. Your facility has to be inspected by the jurisdictional authorities before you can reoccupy. Even though the Currituck facility did not flood, we still had to have a county inspector come in and look at the facility before we could return people. Transportation back to home facility was a challenge, where everybody jumped on board to get everybody out. Getting people back became a challenge. Completion of the Virginia Resident Emergency Evacuation Form. Yeah, that form, we gave up on that. And we essentially sent a spreadsheet to the RHCC here in Eastern Virginia and said, here's who we evacuated, and this is where they went. Because the form we were provided it was just too cumbersome. Our incident command was actually more of an emergency operations center, but it worked. It really did work. Tracking expenses surrounding evacuation and return, we've learned we need to set up independent cost centers to put everything in there. And then, reimbursement of receiving facilities and other resources internally is something we've worked out since then and actually utilized quite a bit with COVID. So a lot of good lessons we were able to apply that are in place that not only apply to evacuation, but also applied for us in running an emergency, regardless of the nature of the hazard. Next slide.
Some of the challenges that the VA has is are political. Oftentimes, because we are a veterans hospital and congressmen and senators take a great interest in what's going on here, we are often complicated by those jurisdictional policies and politics from our congressional and senatorial representatives. Tim Kaine announced to the media that we were performing a full inpatient evacuation, and nearby veteran outpatient clinics have closed in anticipation of the powerful storm. Well, that immediately brings a lot of scrutiny down on the VA. So we were complicated by that. We were complicated by our evacuate or shelter in place decisions, because as I indicated earlier, we often, we are not bound by the governor's decisions on our facility, but in this case, the liability of having a storm as big as Florence coming towards the Hampton Roads area, and the discussions with our network director made it imperative that we make a decision. When we move our residents' supply and equipment, our residents, this is their home. They often don't have a lot of things, but the things they have, they want to take with them. And so that became a bit of a logistical hassle. And how do you use the logistics vehicles to best serve your community, but also make sure that you evacuate the essential things you need to evacuate. What we did do was we color-coded that our spinal cord and our community live-in veterans possessions. If they had a blue armband, all their belongings had blue stickers, and the vehicle that they went in was blue, so that we could keep track of everybody's possessions. Coordination of transportation is always difficult. We know in this area that they could reverse I-64. They've never done it. I hope they never do, but that threat causes us to have to make decisions very, very quickly, and maybe a little sooner than we might otherwise do. And then based on the fact that our entrances, we have two entrances. One goes through Hampton University onto Settlers Landing Road, and one goes directly onto I-64 and onto the Hampton Roads Bridge Tunnel. And that tends to be gridlock on a normal day. And now they're doing construction, and on a daily basis, the backup to get onto the bridge tunnel is 3-4 miles easily on a daily basis. So that's we get a lot of gridlock due to our location. Notifying families and responsible parties of veterans. We have to give them an opportunity to make a decision on their loved one. Where do we shelter staff evacuated with veterans? Richmond and Martinsburg generally have been excellent with taking care of our staff, but that's a consideration that we need to take into effect. And then the storms track changing consistently made decision making very challenging. Next slide, please. Some of our lesson learned. Incident command, no matter how big it gets, is important. Incident command at our facility tends to involve everyone. We don't have traditional incident command chart. We have, as Patty said, more of a emergency operations center. Everybody wants to participate and everyone wants information, so our incident command tends to get very large. Continuity plans are very important. Know what you're going to do, know what the contingencies are for everything you need to do. All our veterans and staff who evacuated and returned without incident. Our resident veterans will not evacuate without all their stuff, and accommodations need to be made. Checklists are important, and it couldn't happen without all hands on deck. Supporting organizations must be notified early, and daily phone calls to family and responsible parties are important. One of the biggest lessons we learned was leaders must be visible, and it's important with veterans to celebrate the return. Next slide, please. And this is our return. This is everybody coming back. Whoops. That's everybody coming back, and all hands on deck when everybody came returned to the facility. Next slide, please. Other lessons learned was there needed to be a formalized evacuation plan. Make sure that you leave a small contingent of staff for facility operations and security. We didn't. We locked the doors. We completely closed the boiler plant, causing leaks in our system and exposing our utility vulnerabilities when the steam was restored. And it actually caused millions in damage because of the age of our infrastructure. We had a lack of a use of an alerting system, and they determined at that time it was important to hire an emergency manager. I have added to this the evacuation plan that we created for everyone's use. I got permission from our director to share it with the community. Next slide, please. Our follow-up in April 2019, I was hired. They formalized the position and hired me. And then in November 2019, we created an evacuation planning group, which met to form, we were formed to write a plan. In June of 2020, we exercised our draft plan, and in August, we finalized and formalized our plan. September 2020, the plan was shared with the entire Veterans Health Administration as a template for evacuation, and that's why we're sharing it with the community. January 2021, we implemented the emergency alerting and accountability system, and it became mandatory for all VA-owned cell phones and computer equipment, and we use it quite frequently now, and it's become a successful integration for notifying our staff. Next slide, please.
Thank you, Leanne. Thank you, Patty. I just wanted to express the comments that are coming through. Thanks for the presentation. Thanks for the takeaways to include documentation. So want to extend that from the listeners. And first question is for both presenters. Patty, if you want to, can you kind of tell us more about your transportation MOUs and any other MOUs that you have for other facilities, organizations to receive your patients, as well as for you to accept other organizations' patients?
Yeah, I mean, we have the transportation MOUs. The one that the big one for this particular exercise had specifically to do with the Pasquotank EMS. North Carolina EMS operates a little bit differently, where some of the jurisdictions not only provide EMS services, they provide transport services. So it's kind of a non-competition MOU, but when we had to evacuate, they were like, yeah, fine, bring your own transportation in. Being a large health system, we kind of have the luxury of telling our member hospitals, hey, you're getting these patients. And the same thing was true of long-term care. We do have MOUs in place with our other coalition partners to cooperate in the event of any emergency that goes on. And, you know, fortunately, we didn't have to leverage any of that because we were all dealing with a similar situation. I think one of our gaps, though, from the Eastern region would be moving out of the Eastern region. And as I know, you know, for the Central region, one of their big risks is an evacuation of the Eastern region. I don't think we have the necessary MOUs in place to help us facilitate that outside of our region. But I know there are transfer agreements in place between all the Sentara hospitals and was in place between the Sentara long-term cares. And we have a great deal of regional cooperation in the Eastern region. I think there would be a gap or need once we went outside our region. And we do need to, and we're in the process of addressing, Sentara divested of medical transport. It's not another company, I think it's Midwest Medical, putting MOUs in place for that. So that's a work in progress right now.
Thank you, Patty. And Leanne, same question. Can you give us some insight as to your MOUs, internal, external, so receiving patients and accepting or transporting patients to the facility?
We have a ambulance contract with Reliance Ambulance right now, and they routinely move veterans for us. And during severe weather, we frequently contact them early to notify them that we will be needing them to at least move our spinal cord and our mental health patients. So those are managed through our Health Services Administration, and they do a good job of maintaining them. They're in constant contact with them even now because of their relationship with us and moving patients to get them to their medical appointments or moving them to get them to dialysis. Those are long-term MOUs, and I believe they're for either 3 to 5 years, and every few years they have to renegotiate them. As for government contracting, those MOUs have to be competed. So when they do one that is getting ready to expire, they have to put it out in the community for different organizations to bid on it. And we are governed by federal contracting law.
Thank you, Leanne. And thanks again, Patty. That is all the questions I have at this time. We'll give it just a second, and then Matt, Mary will close us out. And I want to again, extend my appreciation to the presenters, and thanks for the attendees.
Yes, thanks, Matt. And on behalf of the Virginia Hospital and Healthcare Association, I'd like to personally thank our member, Sentara Health, and Patty Montez, along with our great federal partner, the VA Medical Center, Leanne Erdman. Thank you both for sharing your lessons learned and expertise with the Commonwealth today. And this concludes our quarterly webinar. Please join us on June 1st as we'll have a statewide communication test along with the National Weather Service joining us to kick us off with a briefing for the 2022 hurricane season. Again, thank you for joining us, and the slides will be sent out later this afternoon. This concludes today's webinar.